conference.
Thank you. And hello, everyone. Thank you for joining us for the latest session of the DaVita PD webinar series. This series covers the key clinical elements of managing patients on PD and is recommended for all DaVita nurses, medical directors, as well as any physician who has or plans to place patients on PD. Today is a mix of physicians and DaVita teammates, and we're happy to see that there's such growing interest around the therapy. You are eligible to receive one continuing education credit for today's presentation, as well as one credit for each of the 5 previous webinars in our current series. Reminder, all of your webinar sessions are recorded and available for on-demand access. We'll reference previous webinars in our current webinars, so feel free to go back and watch the past webinars as a reference. That way you'll be able to follow right along with what we're saying. Also include a Q&A session at the end. You can ask questions in multiple ways. You can wait till the end of the presentation and ask your questions in person, and our operator, Sarah, will help facilitate that. Or you can type them into the chat box of your webinar panel, and I'll go ahead and ask those questions for you. Today is kidney transplants and PD patients, optimizing PD treatments to ensure candidacy for transplantation, certainly a topic that is near and dear to the hearts of all of our nurses. So I'll pass the mic on to John Rand, who will introduce today's speaker. John?
Good morning, everyone, and welcome to this webinar. It's a pleasure to introduce Dr. Hector Rodriguez and some background on his bio. He studied medicine at the National University in Bogota, Colombia, and afterwards came to the U.S. to complete his medical residency at Barnes Hospital, a very famous institution in St. Louis, Missouri. He would get his PhD in biochemistry at another famous institution, UC San Francisco, and do postdoctoral fellowships at both UCSF and Washington University in St. Louis. He's certified in internal medicine and nephrology and is a clinical professor of medicine at UCLA's David Geffen School of Medicine. He's currently on the Southern California Renal Disease Council Medical Review Board, a developmental director at Cedars-Sinai Center for Renal Replacement Therapy in Los Angeles, and of DaVita's Physician Council, as well as all these other things, being Group Medical Director for the entire DREAM team and the new team, Polaris. You have the floor. Please.
Thank you for the nice introduction. Good morning from the West Coast, and thank you for the invitation. Even though the knowledge on the topic of PD patients who become recipients of a kidney transplant is rather limited, the info level is sufficient to conclude that pre-dialysis patients are no different from hemodialysis patients in terms of qualification for kidney transplantation or clinical outcomes following transplantation. However, PD patients confront some unique problems in the post-transplant period that hemodialysis patients do not experience. What I'll try to do this morning is to highlight for you the evidence published in peer-reviewed journals that support these views. Let me review briefly ESRD patient distribution in different modalities of renal replacement therapy. Annual number of incident patients or patients new to ESRD shown by the bars has increased steadily since 1980. The percent increase per year shown by the vertical lines has actually decreased steadily and leveled off for several years. Has occurred in number of prevalent or existing patients on renal replacement therapy. The majority of new or incident patients enter hemodialysis, as shown here, or enter peritoneal dialysis or are transplanted. These are failed efforts to achieve significant growth of PD. And less patients enter PD, the number of patients on PD shown here remains very, very small. Now, that only a small percent of patients, more than 20%, show these dark blue bars, entering dialysis because of diabetes or because of hypertension, receive pre-ESRD care by a nephrologist for 12 months prior to initiation dialysis, whereas a larger percent of patients with glomerulonephritis or cystic kidney disease do receive pre-ESRD nephrology care, nearly 50%. This shows to me that internists and primary care doctors are not making timely referrals to a nephrologist for patients with two most common causes of CKD, those being diabetes mellitus and hypertension. And if so, they are indeed preventing or depriving CKD patients of good comprehensive pre-ESRD education and entering peritoneal programs. Aware of the substantial difference in cost between hemodialysis, nearly $80,000 per year, and peritoneal dialysis at nearly $60,000 per year. The cost of transplantation is even lower than that of any of the dialysis modalities. With the global decline in the economy, we're seeing countries beginning to look at PD as a preferred modality. In instance, United States, 45% of ESRD patients are transplanted. 4% enter peritoneal dialysis programs. Now they're beginning to realize that if they were to increase peritoneal dialysis by 25%, they would save 155 million euros per year. And needless to say, by increasing transplant by 9,000 per year, they will save over 2.5 billion over 10 years. So we will see more and more in foreign countries, particularly Europe, a tendency to increase in the number of patients in peritoneal dialysis program. Now, I mentioned to you that information on the topic of discussion this morning is rather limited. This slide is an example of the problem. Of MEDLINE over 4 years, there were 10,088 citations for kidney transplant and 12,078 citations for dialysis, for renal dialysis. Those only 2,465 citations were for peritoneal dialysis, but only 125 citations found that covered both kidney transplantation and peritoneal dialysis. Most of the information that we have in this field is rather limited, but I believe it's good and it allows us to draw some relatively firm conclusions in terms of the feasibility of peritoneal dialysis patients going into transplantation. Now, reviewing the outcomes in general of patients who are on peritoneal dialysis and are transplanted. The best study on this topic is probably the one study done by using the DaVita database of 14,580 recipients. Here is that in this group, when you compare peritoneal dialysis patients versus hemodialysis patients, the survival of dialysis patients after transplantation was superior to that of hemodialysis patients. The graft survival or kidney transplant survival was also better for peritoneal dialysis patients. The cardiovascular survival was much better for patients who had been on PD prior to transplantation, and the survival or cumulative survival of all these factors was indeed superior for peritoneal dialysis patients. Now, this is done for the whole group of the 14,188 patients. Now, do what is known as a propensity scores analysis, meaning that each PD patient was compared to a hemodialysis patient who had similar age, sex, and comorbid conditions. So the difference between the two groups will be the modality of therapy, that being peritoneal dialysis. It was found that indeed, when you did